So thank you very much for the introduction, and thank you for having me today at such a prestigious event. It's fantastic to be invited along, and today I wanted to talk through our experience through the beginning part of the COVID first wave, and how the unthinkable triggered the unimaginable. So by way of introduction, my background is as a clinical pharmacist. I'm also a qualified clinical safety officer. And about 18 months ago, I took on a role as the Trust Chief Information Officer. So rather embarrassing to have technology problems at the beginning of this presentation, given my working role. I'm a board director at the hospital, and some of the things that we experienced through the COVID as a leadership team, through the COVID crisis as a leadership team, I wanted to share today. But more broadly, the lessons learned were shared across the organisation. They weren't just focused on leadership. Before I wanted to dive into the session today, I wanted just to echo Roy's words on the previous session and mention that there's been a huge human cost to COVID, and it continues to affect many people in the UK. I don't want us to lose sight of that, and we shouldn't forget it. But today, obviously, I want to focus predominantly on a 2-month period at the height of the first wave, where some really fabulous change occurred because of the work of our broader teams across the organisation, and a willingness to really change the way we operate. So, the unthinkable. In March this year, we woke up to the fact that there was a very real threat to life on a large scale in the UK. By the 3rd week in April, the country was in lockdown. The scale and size of this mandated emergency response had thankfully not been experienced in generations. The unimaginable, the response at a local level, as well as the change in the approaches for the emergency phase of the response at a national level, really did make us address things that had previously seemed huge issues that we couldn't overcome. And I'll talk about some of those in today's session. I think one of the key principles about this was a common focus, a common foe in COVID. But one simple illustration that I'll pick out later in the session today is that months before, about 6 months before the first wave of COVID, we found ourselves in meetings having very difficult discussions about how we might virtualise the follow-up of outpatients to meet the long-term plan. And we really were running out of ideas how we might hit this 40% target of virtualised outpatients. And that really did feel like a tall order for some reason. And that's something that evaporated fairly quickly as we moved through the COVID crisis. Go on to the next slide, please. That's good. That does mean people can hear me. When forming a presentation, sometimes you get the inevitable writer's block. And so a great place to go is Brian Eno's Oblique Strategies. These are a deck of cards, or they are available online, of phrases and statements that get the juices flowing in terms of unblocking that thought process. And one that struck me was a reflection on perhaps how we did see things in the NHS in more widely, that changing nothing and continuing with our immaculate consistency was a great idea. Obviously, I hope this presentation picks apart that. And I think what we'd like to do is move on to our story in the next slide. Have the next slide, please. So thank you. The next slide really just outlines the challenges, and I think these are challenges that we're probably all very familiar with. These face most organisations in the NHS organisations in the UK, and they were there prior to COVID in varying different scales. And it's not surprising that there became an immediate need to address these elements as part of the emergency response. So these elements are access. So this is access for patients and citizens to care. What became more apparent in the COVID crisis was the access of loved ones to contact each other, where one member of their family may be in hospital and unwell, and visitation was restricted or not permitted at that time of the crisis. And so providing that access between patients, loved ones and citizens to get care or to be in touch with each other was something that became ever more important. I also mean access in terms of our workforce and the ability for our workforce not only to access clinical and care records in a longitudinal manner, which I'll talk about today, so that across the care pathways and across the care system, information flows so that we can give the best care and make senior clinical decisions earlier in a pathway. But also that for our workforce, access to information to allow them to manage their sort of health and well-being as part of the crisis was vital. So access is a really key point. The second element that's probably a challenge for many providers is collaboration. There's always a will to collaborate. We want to work together, but we tend to work in very transactional ways. We tend to think of form over function rather than working in a truly collaborative manner. And a great example of that is, just in simple terms, is email. We send emails, there's strings of emails back and forth all day long to each other, rather than collaborating around an issue, bringing the skills into the room and solving in that real time. And we did see changes in our unified communications during the COVID crisis, and I think probably most people now, although I failed at the beginning of this presentation, are fairly used to video conferencing using Zoom, but things like Teams and collaborating around documents. The final point here is integration and really integrating in real time, and that's care information, as I've mentioned before, and linking that flow of information that we'd heard from the last presentation right across our acute community and primary care teams. But there's also that linking of information of our workforce as well, and making sure that we're looking after that workforce most effectively, and that they're cared for, and that we're supporting their well-being in what was really very challenging times, and continues to be so, perhaps more so now. So as I mentioned in the introduction, meetings only months before were struggling with some of these sort of challenges that were present already. And we'd also had discussions around our population health platform. We'd already had something in the proof of concept mode. We were planning to roll more out in the year. And there were lots of conversations around this longitudinal care record, and was it fancy? It felt like a great idea and we all wanted it, but it felt too far away. In fact, the word interoperability had become such a swear word that I'd stopped using it about 12 months ago, because it really turned people off and disengaged people from pulling things together. And what we really needed to do was to focus on what the problems were and find the solutions for them. We also had in the organisation pre-COVID something that I'll talk about later around the culture of digital confidence. I think most people find technology threatening in some way, in terms of it might be something they're not confident enough to talk about, and therefore decision making around using technology is something that's really important. At the beginning of the COVID crisis, and something that we're actively refreshing in our digital strategy and our board strategy at the moment, is that our board assurance framework focused on a risk around would people adopt technology, whereas I think much more now it's can we meet the expectations of our workforce with technology, and that's something we're actively working on at Dudley. I'd also recently, pre-COVID, to address some of these challenges, embedded a digital skills framework into our Dudley People Plan. And I have to admit that I was probably quite nervous about what that meant, because the action plans to deliver that and broaden the kind of digital ready workforce, which is a programme available through NHS providers and Health Education England, is something that was going to be a challenge to embed in our organisation. And I think my view of that now, 4 or 5 months later, is very different. So if we could move on to the next slide, I think people will be familiar with memes and various different things that have been out there in social media that exemplify this. But on the 23rd of April this year, we went into lockdown. The key message was stay at home, protect the NHS and save lives. And over the intervening 7-week period, which is the focus of the rest of this presentation, until restrictions began to be relaxed on the 10th of May, significant and progressive adoption of digital solutions ensued. The world soon began to focus on the relative importance of different things, and this is kind of sketched out in the graph. So work tracksuits, the availability of toilet roll in the supermarkets, how to sing 2 rounds of Happy Birthday whilst washing your hands, and also the need for laptops, the demand for which was a pull for more and more technology. For me, at least, probably the only consistent item through that period was the relative importance of coffee in my day job, and I think that was probably fueling many of our colleagues, because it was long hours and it was a lot of work. Remote working was something that became really key as a driver, and using our workspaces more flexibly, and progressively through that period of time, creating the social distance needed in workspaces. The access of social media, as I mentioned before, for loved ones to contact family members in hospital became really important. Virtual business meetings and team meetings and collaboration with our workforce that was then all of a sudden spread from a remote environment at home, through the office environments in the hospital, through the active clinical areas, which obviously we were protecting to make sure we were embedding great infection prevention and control procedures. More and more virtual multidisciplinary team meetings. During that time, we also at Dudley managed to deliver a remote home reporting solution for our radiologists, so they had access to the compliant high quality 4K screen, so that they could properly read images and report from home, so that we could protect elements of the workforce. We expanded the use of our population health platform, which I'll talk about more, and we reconfigured our electronic patient records so that they could support tracking and tracing patients through the organisation when results for COVID tests were coming back or when they were due. And we also had to reconfigure our clinical spaces throughout all of that time fairly dynamically, so that we could manage where people were. So there was lots to do. We also created an in-house staff testing solution within that time that we built in-house with some of our fantastic developers, and it was really a credit to them, where we were able to turn around staff tests within a 2-hour window via a text message and SMS solution. So much so that we then supported our borough-wide health and care key workers and started doing the testing for their workforce, because we had such a slick process. And there's a huge amount of work and a huge credit there to our lab staff as well. So I think I want to explore what enabled that change in today's presentation, because I think that's important, and sharing those lessons learned, because we did lots of exciting stuff that made a real difference, but I think we need to explore probably what's behind that. If we could just move on to the next slide, I want to explore the kind of main enablers of that change, and my reflections and those of others that got us to that point. I think that's threefold. I think that's funding streams, a shared common goal, or it might be called a common enemy, and partnership. I think the funding route, particularly at the very beginning of the COVID crisis, where delegated authority came down to trust board level, made decision making really clear. It had to be evidence-based, as it always would be, and I'm going to talk about the governance mechanisms and the agile governance that we used later in this presentation. But I think that COVID budget line really got the ball rolling in the right way, and we were able to unblock some of the challenges that we'd faced before about our financial flows, and that allowed us to move into a much more agile way of working. And I know that during that time, certainly as our STP and our wider system, we sort of talked about what seemed to be a technology windfall, but that set new expectations and created its own new challenges. I think that as a leadership team and as an entire workforce across the NHS, across all key workers, but particularly my experience of our story at Dudley, is that we were focused on this common goal or common enemy of COVID, and that allowed us to really keep our decision making focused. I think that process isn't sustainable in the long run. Obviously, healthcare is incredibly complex, and you can't always just focus on one thing. But it is something that, where there is a common aim or common goal, I think we can learn lessons about how we more effectively drive towards that in the future. And the last part is this partnership working, and I think that's partnership across systems, but also with our suppliers. We had a fantastic response from all of our suppliers in working together with us in those following those same principles, the common goal, breaking down the traditional barriers that were within organisations that allowed people the freedom to act, to move things forward, and use their use their autonomy as a professional, whether they be in a supplier organisation or whether they be within our trust or within our system partners. That allowed us to really focus on what we were trying to do for patients and the public. But a reflection of that is that probably during that emergency crisis phase, the voice of the citizen was largely absent because of the rapid decision making, and that's something that in the future we need to make sure that we build back in. And I think that is a challenge that we'll consider going forward. And so the normal mechanisms that we would have were broken down, but they did enable us to move really quickly. If we move on to the next slide, this next slide, I think everyone's fairly familiar with. I won't dwell on it, but it's just that kind of a bit more detail about understanding the issues. Is that technology is a solution to problems, and I think it's getting out there and understanding the problems, but really that's driven from people and process and the culture within an organisation. And I think we saw an absolutely dramatic change within our organisation at the Dudley Group through that time period. To put that into context, I have a pet hate, which is the phrase, "it's an IT issue." And I think that's incredibly unfortunate in my role. But the reason I don't like it is it's a term that's used ubiquitously for something that's broken, which is obviously an IT issue, if it's related to technology. Something that a person doesn't quite understand, or they don't know how to use the technology, so therefore it becomes the IT issue. But it's also used for where a digital solution can solve a healthcare problem. And I'm a clinician by background, but translating that to be an IT issue when actually it's a healthcare problem we need help solving sometimes becomes a bit of a barrier for that effective collaboration we've talked about. And I think that we found that we turned the phrase IT issue within that time to a healthcare challenge, and can you help with the solution? And I think that really did or was one of the main reasons that enabled us to move forward at pace. So that enabled the skills and the expertise that was required to be in the room with our operational or our clinical workforce, really outline the problem, the item that we must solve to move things forward, and our technical team to then come up with the best solution. And that really worked well as a team, a very agile working environment, and built into the governance that I'll talk about next. If we could just move on to the next slide. I wanted to sketch out for people on the call and on the presentation today the approaches we used. And I think just to move on from that last theme, the previous approach within the organisation on reflection was much more around push. We have our Dudley improvement practice that we use, and we use the same principle as a PDSA cycle of evolution, and we are working through that. But a push mechanism, you can see from this daisy chain of paper clips, if you're always pushing the solution that you think is defined from the beginning, quite quickly that daisy chain collapses and doesn't advance towards the goal. It becomes a mess. And our new approach that we sort of learned through COVID was to pull, and that was to define the problem that we were going to need to get to this common goal. And if we all pulled in that direction, the daisy chain quite quickly straightened out. Process to get there became much more efficient, and it was less messy. At the same time, we use this kind of sprint methodology for our agile governance, and we set up our clinical safety reviews twice a week, so there's a real cadence to that. So that involves senior decision makers, our CCIO, myself, the medical director and the chief nurse meeting twice a week to approve the principle of an item or approve the release of a new clinical change. And that really did speed things up and prevented any blocks, that you'd normally find in a monthly governance cycle. Now, whilst that's not necessarily sustainable in the long run, the principle of having the right senior decision makers in the room that are able to listen, assess, and actually support teams moving forward with a very clear objective is something that we are building into our new mechanisms because of that learning. If we could move on to the next slide. I think one more point just there is that around that approach, we stopped letting perfect be the enemy of good. And I think that you can have a good solution that you then evolve quickly through that agile mechanism. And I think the key that helped us move forward and the real change there was that by honouring that agreement to iterate and improve on rapid cycles, we kind of got to a position as an organisation where we trusted that that would happen. So the first iteration may not be perfect, but it would absolutely move us forward. And that's something that we then moved into kind of a paradigm shift. The technology became an enabler. Went from being an enabler to the technology underpinned a safe care delivery pathway, and that was because of a number of combined deliveries. So I'll try and keep this brief. I'm just conscious of time and that we started a little bit late. But what we did was we got early access to information for senior clinical decision makers. We used our Allscripts DB Motion platform to make sure that we were sharing primary and secondary care data across the patch, and that when patients arrived at the acute hospital, we had sort of clear access of their previous conditions, their medication history in real time within our electronic patient record solution. It didn't require logging on to anything else. It was provided through DB Motion as a notification, and we could act upon that really quickly. And we'd already changed our model so that senior clinicians were closest to the front door, and therefore making that decision about where the care of the patient needed to go next happened sooner in the pathway, and that delivers really much better outcomes. We were able, as I mentioned before, to track and trace patients more effectively by reconfiguring our electronic record. We undertook the in-house development to create the staff testing SMS service. We worked with partners such as Attend Anywhere and WebEx and the NHS Central Digital Team, who made available technology like Microsoft Teams. We worked with our partners that we already had in the organisation, with vis-a-vis our MDT or multidisciplinary team conferencing solution, and they were really on board also with the flexibility around making sure we had enough licenses, enough space to take on those virtual meetings, and supported us through that without creating additional bureaucracy. We created a flexible staff working environment that I mentioned before, and really drove the use of mobile devices, laptops across the organisation. And that was supported by the central funding that helped move that forward, as I mentioned at the beginning. A great deal of the unimaginable cultural change that I mentioned before has been released by remote working and the use of virtual clinics, and something that really did change within a 4-week window, as you can see in the bottom right hand corner, is that we were undertaking 5,000 virtual outpatient appointments a week, and 6 months before we were worried how we might get to 40% of our outpatient contact being virtual. We achieved 60% within that sort of short time window of embedding and rolling out the use of Attend Anywhere as a solution. I think unified communications with Microsoft Teams, and with something we've taken forward in the national N365 Microsoft Office deal, is something that we want to keep progressing. And I think that really has enabled organisations to work in a more live manner and really change the way that we use our facilities and our office space. And I think all of this was enabled by that partnership working I mentioned, and really all coming together. And I don't think it would have happened without the partners that are mentioned here, and the support of each of those suppliers. We can move on to the next slide. I'm not going to dwell on this one because of time, but really just to say, our integration vision in the Dudley system picks out some key phrases here about integrated care services, access, personalised health and wellbeing, and actionable insight, and the data that we can use to steer decision making. And in that very short 7-week window, but progressed rapidly at the beginning, we started to achieve all of these things that had been challenges and unimaginable, or felt that they weren't so tangible only months before. We move on to the next slide. Again, I won't dwell too much on this, but in terms of bringing together that longitudinal record, we heard that in the last session, how important it is to connect up care, connect up medicine, and make sure that we're sharing this across all of our care settings is part of our aspiration, but we've really advanced in that last 4 month period to move much closer to achieving this. And I don't think it would have happened without the cultural and the mindset change that COVID brought for us. And it's really important that we carry on the good elements of that to embed them into practice, because they really do have the patient and the citizen at the heart of that. And we will need this for years to come. And I think it's really important that we continue to progress down that connected up system working, the integrated care system. And I don't mean that from a technology perspective, but I mean that from that true partnership working across health economies. So if I then try and distill that down in the next slide and really pick out the learning and the things that really helped us move forward, and I suspect that this will be something that stimulates questions in the latter half of the session we have today. So what did we learn? I've looked at this as a start, stop and continue. And we're continuing to add into this thought from the second phase that we're facing at the moment. So I think it's difficult to translate a single response into the multifaceted healthcare environment and the integrated care system agenda, but I think we need to do that by picking apart and carefully analysing what we did learn in the emergency response phase. So the start. I think we are starting now to define the problem clearly from the outset, the problem that technology may help, but understanding that the people and process are equally or perhaps bigger partners in coming to a solution there. We started to build a board level confidence in discussing technology, something that we're taking forward at the moment, and the NHS providers digital board programme is something that we're advocating, and we'll be discussing at our digital committee this week, actually tomorrow, with strong executive buy-in already. We started to build an effective patient and citizen advocacy programme into our well-led digital committee, recognising that at the pace of change in that emergency phase, we didn't hear the voice of the citizen strong enough, and I think that's something that we want to recognise and build in and allow that advocacy to help guide us. We're encouraging and started to encourage new and emergent leaders. I think that was apparent, and probably most people will sit back and think of leadership and followership that existed in the organisation, perhaps from people that weren't in formal leadership positions at the time. But I think we want to carry on encouraging that, and certainly in my broader team, we've carried on encouraging that and working to build that into our people plan and our reciprocal mentoring scheme, so that we're sharing that knowledge. It's not just reverse mentoring in the kind of traditional sense, but there's something that the younger emergent leaders have to share with others, and vice versa. The experience shared backwards absolutely improves the way our organisation can move forward. Stop. So what are we going to stop doing at the Dudley Group? We are kind of the converse of what I said before. We're going to stop defining the solution from the outset, which creates a rigid process that often fails to meet the true need, but also fails to meet expectation and kind of causes the collapse of that daisy chain of paper clips. We're going to stop referring to healthcare problems as IT issues when they're truly healthcare problems, and hands up when you have an IT issue, it's an IT issue, as I experienced at the beginning of this presentation. We're going to stop talking with acronyms and technical jargon that become barriers. So our committee is a no jargon, no acronym zone. We want to demystify that so that we feel confident in talking about technology and how solutions might help care. And we're going to stop letting perfect be the enemy of the good. And that's something that sticks with me. The things that we want to continue to use that agile governance process that I mentioned. The governance is vital, but utilising decision making in a different way, I think, is something we've learned a lot from, and that allows us to move at pace with good leadership. We want to continue simplifying how funding streams work, and I know that there's a lot going on across the system and across the UK around funding streams and the availability of funds post-COVID wave one. But that's something that we want to see continuing and removing the bureaucracy around that, or the unnecessary bureaucracy, I should say. We want to continue board level leadership and ensuring that the digital subcommittee of the board is in place with the right membership and involves the right people, so that we expose true issues and that we talk transparently and confidently about how technology really does become the deliverer of care pathways rather than just a simple enabler of operational and clinical items. And we want to continue the strong supplier partnerships that we had before and the shared experience that we've had through COVID together, so that we have co-owned outcomes, a true shared risk profile, so that we deliver together quality, safety and efficiency, and it's not just about financial penalties or contracts. I think with that, I'm left reflecting upon the way that we fund technology traditionally, and I don't know if this is the same for every organisation that's present on this call, but it's certainly out of a number of NHS organisations I've worked in, we look at a business case for change, really focused around a financial case that says, does it stack up? Is there a return on investment? And I think what we need to do differently and carry on focusing upon is the economic case, what that does for the local healthcare economy and the local economy. And that's to impact upon the wider determinants of health within the health system. And that's difficult, and I know that's difficult, but when we move into integrated care system thinking, it becomes a little bit easier, that we won't necessarily see the return on investment where we would want it to be, but it is part of what I would call the Dudley dollar, and that's a part of our economy, and making sure that the money stays within the borough so that it's more effectively supporting job opportunities, career pathways, the wider determinants of health, education, and prevention schemes. And I think that's something that is exemplified in the Microsoft Teams solution that we went live with. We didn't use video conferencing and virtual meetings routinely in our organisation before COVID. In fact, I was struggling at the beginning of the year as to how I'd frame a business case that would say this was the right thing to do. It clearly was. We clearly needed to work in a more efficient manner, but there is no obvious return on investment for putting that in, certainly within a year or two. But the way that we can move differently as an organisation and release our wider organisation as a state to do more for caring for people absolutely is a benefit, and the wider economy as well. And therefore, I think I would have struggled to get the business case for Microsoft Teams through if we'd have remained in our old way of thinking. I had that conversation with one of my finance colleagues recently and said, do you think I'd have got a case through? His view was that I would not have. I said, what would you say if I had to remove Microsoft Teams away from you now? And he said, you couldn't, we need it, we have to have it. And I think that's just a reflection of people's change in mindset. And I think that's the thing that's really enabled us to think differently, to work on innovation, to define the problems that we have, and then find the solutions that we need. That, and obviously within all of that process, the supplier support that we had to do that, and I think we need to work with those partnerships really closely going forward, and that's sort of a plea really for everybody. So finishing it off and then leaving some time for questions, I hope. Just move on to the last slide, and I'm going to go back to Brian Eno's oblique strategies, and obviously I'd expect everyone to challenge this statement that repetition is a form of change. It really isn't. We need to change the way we think and the way that we do things, and the learning that we took at the Dudley Group from COVID has really changed that for us as an organisation, and I think it's embedded in our psyche and it's affected our culture positively already. And I'd like to thank everyone there for listening and ready to take questions.
Adam, thank you so much. I am so in awe of what you've achieved and what you've spoken about, and I think I just genuinely couldn't note things fast enough in certainly the last 20 minutes. I've got some questions, but the audience has got a few for you too. So firstly, thank you so much. I think the sharing and the learning is immense, and I'd like to come back to that. We have a couple of questions, so I'm going to go straight to those if I may. So Alison has asked, have you got a target now for how many appointments will remain virtual?
Yes, we have, and we really want to keep a principle of that. it should be virtual by default, but we also are recognizing that there are care pathways where that isn't appropriate. So we are continuing to try and push for at least half of our appointments to be virtual, but we're working on a set of principles that we haven't finessed yet, but a set of principles that enables us to establish if it is appropriate or not. And that framework is intended to support clinicians and consultants. And I think it's easy, having been an outpatient clinician in medical oncology. Now, that's clearly a pathway where your first appointment with a patient, you wouldn't want it to be virtual. You want to be there to support the individual. But having a framework that guides that would get some standardization and support for our clinical teams in making those decisions. So we want to keep it above 50%. We want to use a principle of digital by default. I'd hope that we could go further, and particularly with our outpatient follow-up and how we share that with our community and primary care partners is something that we need to also work on. And that's part of something that we're working on in the Dudley system about getting care closer to home. You can't get closer to home than a virtual outpatient appointment. I'm sat at home today speaking to you guys, so that's something we want to keep doing.
Excellent, well done, thank you. A second question is from Susan Venables, who's with Highland Marketing, one of our sponsors and the enabler of our PR and marketing around Fab Change. And she says, thanks, Adam, insightful presentation. What do you think needs to happen to ensure that we do not revert back to old habits and processes? So much has been learnt and good has come out of these challenging times. Would it be a shame to lose it? No going back, as Fab Change 20 says.
Yeah, I absolutely agree, and thank you for the question. We can't lose it. We simply cannot lose it. And I also think that we're all now facing probably the most challenging phase of COVID yet. We're going through restoration recovery. We're continuing to support elective care pathways at the Dudley Group and making sure that patients in the wider health system are treated and not just focusing on one particular problem. And that's what I sort of teased out in the presentation, that healthcare systems are multifaceted. So I think you have to pick that learning apart and recognise that you can't just apply phase 1 to phase 2. They're totally different in their makeup. I think I have a little bit of an issue with, it's not a major one, but with the no going back. I agree with the sentiment, but something that we advocate and we have a programme at the Dudley Group is our future. And we want it to be forward thinking, but we also want it to be our. It's a sense of agency across the entire organisation that we own this together. We're all responsible for making that change happen, that we disregard the things that we learned quickly didn't work very well and write that up as evidence that these didn't work, as much as all of the things I've talked about today that really did work. So I think there's some practical steps there, and that's building that through our organisation that we continue to do. But there is no going back. We do have to all take responsibility for our future going forward and celebrate the fabulous change that our teams delivered. And it really wasn't, I'm here representing my organisation, but it was really delivered by our wider teams across the patch, our clinical, our operational, our IT and our informatics teams working together. It wouldn't have happened without them doing that.
Well, listen, you have represented your organisation amazingly today, and one recognises this is a team effort. I mean, the examples that you've given are immense, and I've been in this industry for 24 years, i.e. supplying electronic patient records to millions of people across the UK and Ireland. You've demonstrated how you were able to overcome and adopt things so quickly. And I've taken so much from your presentation that it's about people. How much of it is about to change. And there was one part in your presentation when you talked about the agility of governance, and I was thrilled to hear that you were recognising the citizen needs some advocacy in that. You went on to discuss how you were getting keeping your promise, and you used the word honour, which I think is fabulous, because so many people in all aspects of what we're doing here are honourable in what they're trying to achieve on behalf of everybody, and the immense balance that you have to take, and getting those 2 weekly meetings with your chief nurse and your chief medical officer. And you said, that would have been sort of monthly. It's now bi-weekly. My question is, why does it have to go back? Can you continue to challenge to keep that not unnecessary pace up, but things that are genuinely making that difference to the front line and across as you say, the Dudley Dollar, the STP, the region, and all of the people that you're supporting.
Yeah, no, I completely agree with that last sentiment, and I think we have in a certain way. So to break that down around the governance element, and you might have to remind me of some of the first statements, but to break down the governance statement, it is vital. So we obviously need control, financial control, clinical control, and clinical safety. We need to make sure that interventions are effective and tracked back. So that's a given. But how you do that is really what we changed. We would not have been able to do that had we not had virtual meetings, because we're spread across a number of sites with really complex portfolios to bring together. But we do continue to maintain a cadence. It's not bi-weekly at the moment. And the reason I think that we wouldn't keep a cadence that is bi-weekly is because of fatigue. I think that we've got to recognise that this is a really fatigued workforce right now. And I think we were running on adrenaline fumes to get things mobilised up front, but now we need to be really respectful of people's time, making sure they have the time to do things and not be overwhelming. That said, across our system, we still meet weekly, and they used to be monthly calls. We still have a main monthly meeting, but there are updates and contacts across the regional and system calls using the virtual environment, where previously that would probably have meant getting together as a meeting, driving all over the place. And of course, there's an environmental impact of that. And I think that should not be forgotten within all of this, is that we've been able to work differently, and that's enabled us to blow apart and disrupt the old governance mechanisms.
Well,
if that helps answer the question with it.
You know, it has, incredibly so. I've got one more sneaky one, but you've woken the audience up. They're starting to get engaged. I've got two quick questions. We've got probably 3 or 4 minutes left if all our colleagues are lined up for the next session. So Matthew Little has asked, I'm starting as a digital lead for a trust in the next 2 weeks. What is the one piece of learning you gained through the whole pandemic that you think is key for all trusts to embrace? I think that's a tough question because there's hundreds to choose from.
It's a brilliant question, and congratulations on making a step into digital leadership. I think the more the better. I'd also encourage you. I'm currently enjoying cohort 3 of the NHS Digital Academy, run through Imperial, and with some really fabulous support and fabulous names behind it. So I'd encourage you to seek the Digital Academy out and get on that course. Shameless plug.
I've been mentoring people for a couple of years on that too. I echo everything that you say.
Yeah, hopefully that helps with my marks for the next module if Rachel and the team are listening. The one piece of learning, I think we've just called it out in the previous question. I think it's people. As I said, I come from a clinical background, but people are the key to this, and that's our workforce, that's the citizens before they become patients, and ideally that's what we want to focus on, but also people who are patients. And if you keep your focus on people and how we wrap process around them to make sure that they're looked after, I think that guides what you do and how you take your approach going forward. And that means that you have to bring people along a journey with you, and that is incredibly challenging. So I think you need to be able to put your hands up early and say, we might not be as confident at talking around technology and digital as we are talking about estate, power supply, the sewage system, or whatever. And we need to make sure that the airtime is given to demystify, de-jargon, and talk about digital honestly, and then we'll get better decision making. So key would be people, and then holding your hands up or holding a mirror up at a board level and bringing people on that journey.
Adam, I have to compliment you again in the spirit of openness, what you talked about there. It's speaking in those terms that allow people who aren't normally involved to feel part of it, and that demystification, one can't stress the power of it enough. You're an amazing advocate for how I think I've always advocated good enough is better than perfect. We can iterate, and you've got all of those things working really, really well. The last question we've got, I think in the interest of time, is from Divine. Can you articulate the savings with this innovation in terms of quality and cost? And this helps with a pull technique. I'll be happy to work with you to fully map this for publication.
That's a very kind offer, and thank you, Divine. That's it's a really good point. We've recently been approaching this. So I think from a quality perspective, it's quite straightforward. And what we were able to do was build quality dashboards. We've sort of exploded the use of our clinical and business intelligence with the changes that we made. And I absolutely think in terms of quality and safety, which are obviously subtly different, we can evidence the work that we've done and evidence the fact that injecting senior decision making that's supported with the information that's required to make a decision had really good impacts on our deteriorating patient pathways and made sure that they were maintained, if not improved. I think the difficult thing, as I mentioned in the presentation, is cost, and it depends what you define cost as. I would say that the interventions that we've made have had an economic impact across the whole borough, and I don't think we'll establish a real understanding of what the impact, the size of that impact, for a number of years yet. But I think it'll be the sustained use of technology and continuing to do these things that will enable us to get there and get that understanding. So I think that's challenging. We worked at pace, so we didn't baseline in the same way that you might for a project. We obviously understand the financial cost, and I think there's some challenges coming forward. You know, lots of this was funded gratis, if you like, from companies or through central pots, and we really had good support from the centre in getting things like Attend Anywhere up and running within 4 days. But we need to work out how that's sustainable for the future and where that cost is borne. So it's a difficult one on cost at the moment. It depends if you're thinking of the financial case or the economic case. We probably need to tease that apart, and perhaps that is something we need to work together on.
If I may, and I'm going to be cheeky here, I've worked on procurement. My original profession was as a procurement officer for a private hospital and a group of private hospitals. So I feel a little bit qualified to speak on the matter. But for the last 25 years, I've been supplying. And I loved the articulation you had about changing the business case from the typical ROI, because frankly, I don't think it's worked for the last 20 years. It's the wrong measurements. It's the wrong style. You've articulated what I believe is the right thing. Health is to be stopped treated as a cost. It needs to be treated as an investment. The wonderful Professor Hans Rosling spent 20 years measuring 200 years of development across the world, from big cities to countries. And at every single region, city, town that invested in health first, wealth came. And I think we're entering an enormously powerful session over the next couple of years where we have to regain and change the economy. So the well-being of our people cannot be underestimated. And that measurement that you've described in the middle of all of this, I can't tell you what I think that is such a fabulous learning for the rest of the system. And we must make people in Treasury, the Department of Health, in government. We've got Matthew Gould on shortly after you at 12:30. And I know I'm doing some work as Vice Chair of Tech UK Council with all 180 suppliers that are in this arena, where we're trying to educate and help with the likes of procurement and justification. It goes right the way back up the stream. But if I may, Adam, just as a final point from me, I think we've gone through the questions in the chat. Anybody else has got more questions, we will gather those today. We will share them with our speakers, and we will happily share them out. But the thing that really, really impressed me, and one thing I just wanted to add to, you described the support of the board. Fab change has come from the front line. The evidence that I think you've displayed on behalf of your organization, your colleagues, your passion, your mission, your desire over the last 6 months feels to me that it has come from the board, and you're informing the board. And I'm a passionate advocate of leaders and tried at every level to encourage leadership. Leadership is not from a board or from the top. Leadership is from individual actions. And I compliment you today, and I encourage you that although we must respect the decision makers, the people who have that responsibility, it is so many times through your presentation, probably 20, that I've counted, that leadership has come from the front line. The adoption and advocacy of the new technologies, the new ways of working, the speed, the agility that you describe. It's such a small word to describe such a big thing. And I genuinely compliment you on what you've achieved, and hope that this session can be played back by people. And as it's the sessions under your different slides, the learnings as each chapter has evolved, I think it's a fabulous story. And I would encourage that leadership to continue and to help inform and bring along those executives, because we shouldn't be talking about giving them more confidence, but that is where we are. That is openness, and helping with their mindset to give that more power to time, money, and change.
Yeah, I would completely agree. It's something I'm really passionate about. I'm supported at the Dudley Group NHS Foundation Trust by a fantastic executive team and a fantastic board. But more importantly, a 5,500 strong workforce that have now got their hands on guiding our next steps. So we're building structures in to support that and keep people supported. Goes back to your previous point. Investment in health technology is a massive piece in the economy, and we need to do that responsibly, and that can only come when people understand that the problem they're trying to solve, and leadership and followership are vital to that. And that emergent leaders piece that we saw in COVID is something that I encourage everyone to find those young inspirational emergent leaders and bring them on. Don't be threatened by that's building a network for the future, and that's what we've got to absolutely do. Got to feel confident with talking at technology.
You've so overcome that leadership thing is encouraging leaders. The more that we lead, the more that we achieve, the more we can achieve together. And I have to say, I see you as one of those amazing emergent leaders that I think, delighted we could give you a voice today. I encourage you and welcome you to go on to be a national and international voice, because your examples that you've articulated on behalf of your region and of your organization have been fantastic, Adam. We're going to wind up there. I can't thank you enough for taking the time out. We wish you well with this next phase. This is going to be a really challenging winter, and it sounds like you've really thought things through. You've learned a lot, and you're going to take that forward. Thanks for sharing with Fab Change Day. Thanks for sharing with our audience. And I'd like to say cheerio, and I'd like to welcome now